Today, let's talk about laryngospasm, an important concept in pediatric anesthesia, relatively common and potentially life-threatening. It's important for us to identify this quickly and treat it effectively. So, what is laryngospasm? It's a reflex closure of the false and true vocal cords in response to an external trigger. You can either have the vocal cords completely closed, allowing no air movement through the vocal cords and no chest rise, or you can have a partial laryngospasm where there is a small gap in between the vocal cords and there is some air movement, maybe some chest rise, but likely not sustainable. So now you have a child coming to your preoperative holding area for ear tube surgery. What questions do we ask? Do we care about the age of the child? We know that young children and infants are at a higher risk of this complication. And we also know some of the major risk factors are upper respiratory tract infection, asthma, and exposure to secondhand smoke. So let's look at these. URI. What questions do we ask? We need to really know what the severity of this illness is. Ask about fevers. Ask about if there's copious, purulent nasal drainage. Has the child been eating okay? How's the activity been? All these give you some clue to the severity of this illness. Regarding asthma, ask about the general control of asthma. Has there been any recent flare-ups? Nighttime cough. The frequency of nighttime cough during the week. Is it more than twice a week? Any recent steroid use or hospital visits? All these cues to help you understand the level of control of asthma in this child. And secondhand smoke exposure. So why do we ask this? Because we really need to know if we need to reschedule this elective procedure in the interest of the child because there are a higher risk for airway complications, specifically laryngospasm. If you have asthma and URI both together, that's a bad combination. A strong consideration needs to be made to reschedule this procedure. Is it really important, IV versus inhaled induction? You'll see in pediatric anesthesia, most kids are induced with a face mask. So why do we really ask this question? So it's a conceptual thing. Prevention of laryngospasm is directly correlated with the depth of anesthesia. So if I have an IV in place, I can get to a deeper level of anesthesia rather quickly. So that'll be my preferred choice. Obviously, that's not what we do in day-to-day practice. Most kids go to sleep with a small face mask. But it's even more important to understand what not to do when the child is not deep, even with a mask induction. So when you're having a child in a stage 2 or excitement phase, try not to place a tourniquet. Try not to place an IV when they're still moving around, when they're still excited, because those are triggers for laryngospasm. The worst thing to have is an unsecured airway and not to have an IV in place. The same is the case for an emergence. A lot of pediatric anesthesiologists are particular not to have a Bovie pad removed, or a diaper changed, or even a patient moved from the table to the stretcher when the patient is light or when they're in stage 2 of anesthesia. They do it when they're either awake or they're deep. So it's a big deal. The type of airway device. There is really no data as to an ET tube or LMA helps or hurts. What we know is deep extubation with an LMA does decrease the incidence of laryngospasm, and you'll see that as a common practice in pediatric anesthesia. And we also know that airway procedures, ENT procedures, bronchoscopies, are a high risk. I have nothing against trainees and budding anesthesiologists, but experience does matter. The more times you see this, the more times you're able to identify and act quickly. So it's been proven that experience is critical. And it's even more important if you're relatively young in your career to ask for help quickly, because this is potentially life-threatening. So just to recap, we talked about intrinsic patient risk factors, we talked about external factors, and it's important to have a risk assessment and have a good plan before you start the case. So now assume we're done with the ear tube surgery, you're emerging, now you see some tracheal tugging. Is this normal? So the answer is obviously no, but what does this really mean? It really means that the patient's working hard to breathe. Other signs would be retractions in the supraclavicular area, diaphragmatic splinting, intercostal retractions. Sometimes you see flaring. Occasionally you hear an inspiratory stridor. All these are not normal. So the first thing you do is you readjust your mask, make sure you have the right size mask, do a chin lift, jaw thrust, maybe even place an oral airway. All this to relieve the airway obstruction, which is the most common cause for an increased work of breathing. Well, the saturations are still 97%, doctor. So you have nothing to worry about. Pat yourself on the back. You're doing great. Right. No. We did our initial maneuvers. Has it helped or not? Is the chest moving or not? Those are questions you need to ask, and you need to reassess quickly. And how do I really know? We don't have a bronchoscope or a flexible scope to assess if this kid is laryngospasm. So if your initial maneuver did not help relieve airway obstruction or even enable you to ventilate, assuming this is an effective maneuver, now you're in laryngospasm, either partial or complete. It doesn't matter. You have poor air entry. So again, just to recap, increased work of breathing. You also sometimes see paradoxical chest movements back and forth of the chest wall. All these are clues for you to intervene quickly. And timing. Most of these happen during induction or emergence. Emergence more than induction, but those are critical times. And don't wait for the desaturation, because hypoxemia and bradycardic arrest can ensue rather quickly. It could be a quick downward spiral for us. So now I don't have an IV. What do I do? So you'll notice this classic maneuver of a pediatric anesthesiologist. It's called the Larson's maneuver. So you'll have a pediatric anesthesiologist have an oral airway placed, but with chin lift, jaw thrust, the provider does a painful stimulus in the retromandibular area. It's called the laryngospasm notch, really. It's the junction of the condylar process of the mandible, the mastoid process, and the ear canal. You apply pressure for about 3 to 5 seconds. So that painful stimulus causes an activation of sympathetic nervous system, a fight-flight response. The child cries and opens their vocal cords. Voila, you treated this. You saved a life. This literally is the epinephrine of a pediatric anesthesiologist. Well, we again assess, did this help or not? Are you still moving air or not? This has to be rather quick. And by this time, hopefully your assistant has placed an IV. And if, in case this maneuver did not help, you then move to your IV agents. You start with incremental doses of propofol, 0.5 milligram per kilo. In most of the cases, the laryngospasm is relieved. But if not, quickly proceed to paralysis with succinylcholine. The dose for IV would be about 0.5 to 2 milligram per kilo without atropine to counteract the bradycardic effect of succinylcholine. But then your assistant is struggling with the IV. So is IM an option? Dire circumstances call for dire measures. Yes, IM is an option. But you want to achieve paralysis rather quickly. So you need to give a higher dose of IM succinylcholine, about 4 milligram per kilo, to achieve paralysis in about 45 seconds to a minute or so. Hopefully, you still have perfusion to the extremity or the muscle where you're injecting, because sometimes you can have bradycardia and arrest and no perfusion, so then you'll have variable absorption. So as you see, it's critical to have this in your emergency kit or a box, because laryngospasm can happen anywhere, anytime, and most commonly in the recovery room sometimes. There is evidence to show that giving IV lidocaine 1 to 2 milligram per kilo or topical lidocaine prior to extubation. Yes, this patient we have not intubated, but if you extubated and you're emerging, giving lidocaine does help in preventing laryngospasm. So just to recap, early diagnosis is crucial, doing your initial maneuvers, and then quickly moving to deepening or paralyzing. Thank you.